So the topic given to me is artificial intelligence in dermatology, skin lesion classification, and melanoma detection. See, dermatology per se, the very look at things should give you a diagnosis, and sometimes it can be a very, very difficult thing to differentiate between conditions. So the objectives of today's whole presentation will be to understand the application of artificial intelligence in dermatology, to review skin structures, lesion types, and the context of melanoma detection, to explore image-based workflows and AI model architectures used for lesion classification, and to examine current performance benchmarks. What are the benefits, where we have difficulties, and the limitations, and where we have to overcome or where we have to get a little more clarity, and to discuss the integration of AI tools into clinical dermatology practice and the future of all these. So let me just first introduce you all to skin, which is the largest body organ. And this shows a vast range of lesions, benign, pre-malignant, malignant. There are so many things, from a simple acne, from a simple skin tag to something really malignant, like the malignant melanoma, which is the topic for the day. There are so many things which fall in the gray zone. So there's a visual overlap which exists between these benign and malignant lesions. And our major motive in rapid evolution, but usually it is a small lesion which gradually grows, gives some changes, and then changes over to malignancy. So, where should we exert caution? When is a red flag to be raised? All these small accumulates AI can help us with. So, early detection of malignant lesions, I'll tell you what are the advantages, especially the melanoma. See, it dramatically improves the prognosis. These days, there are a lot of advertisements which says that cancer is curable. Come to us, we'll take care. Life is going to be the same. Yes, of course, if you catch it early. And the visual assessment has inherent subjectivity and variability among clinicians. See, a clinician in India is different from a clinician in British, right? So what we see here will be entirely different about what they see there. Here, a red patch will indicate a fungal infection or something here, which is very common here. Whereas a Brit doctor will not feel like that. There, all these skin malignancies will be much more common, and lesions or conditions of skin, it varies from areas to area, and you need a current ground truth diagnosis. Of course, histopathology, that is the biopsy and the study of the structure, the cellular structure, that is the definitive diagnosis when it comes to any condition now in dermatology. But somewhere we have to decide where we have to go for a biopsy. Is it essential to do a biopsy right now, or should we wait for some more time? So for all these, we need your help. So this is a skin anatomy. The upper part, this is called the epidermis. Then comes the dermis, and then comes the cushion, that is the hypodermis, which is the fatty layer, which we call the subcutaneous layer. And here in malignancy, we are very much involved in this epidermis and dermis. I will show you the structure of this uppermost layer, and I'll explain to you why this is very important. All right. This epidermis, this is a barrier. It protects us from many physical, chemical, and microbial traumas. Right. So you're going to get exposed to sun. It is the epidermis which is going to come to your guard first. You're going to get exposed to some detergents or something, then yes, it is the epidermis. Only after the epidermis gives way, dermis comes to play. All right. So this is the epidermis, that is this small structure that we see here, that is enlarged here. So this epidermis, it has got 5 layers, right? This is the stratum corneum. Then there is a stratum lucidum, which is transparent. And then this is a granular layer, spinosum, and then the basal layer. And this black dragon that you see here, this is our hero, the melanocyte. The cells of the melanocyte, we call these as keratinocytes. And for every into melanocytes. And this melanocyte, this is going to give you the melanin pigment. The melanin pigment is going to form inside this melanocyte, and this is going to spit it out to all these adjacent keratinocytes, right? This melanin, this is the reason for our skin color, for our hair color. It's present in the for a corneal color, the eye color, and then it's also seen in the brain. So the number of these cells do not change in different ethnic groups, be it an American, be it a Brit, be it a Mongolian, be it a Nigerian. This melanocyte number is the same, but the amount of melanin pigment produced and size of the melanosomes, that only matters. And this is very, very important because it is this melanin which is going to give you a protection when you get exposed to sun rays. So why are these foreigners taking sun bath? They want to tan voluntarily. They want to tan themselves, right? Because this tanning, that the process that we really hate, where we find that our skin is going dark, that is very, very, very protective when it comes to skin malignancies. So before we step into the topic, we have to understand that there is a Fitzpatrick scale which grades from type 1 to type 6 the skin colors. All right. We Indians, we fall somewhere between 3, 4, and 5 because there is no strict black and white. There are many, many gray zones. And between type 3 and 4 also, we will have a lot of shade differences. So the melanin index, that is the amount of melanin, this is not the cell, but the melanin pigment produced. The melanin index keeps raising as we go down the types. All right. And again, the UV sensitivity. That is how sensitive we are. We always see the sports person from other nations wearing some white casts, right, on the face. These are all sunscreens, the physical sunscreen, because their skin burns, it never tans. Our skin tans and it rarely we go for burns. Not that we don't go, but rarely we do go. But usually our skin tans. So that is the difference. So for them it is burns, and for us it is tanning. And tanning is comparatively a very, very, very safe thing for our skin. So again, why should I worry about all these skin colors? It is important to us because you see this picture, you see a patch there, and you see a patch on the right as well. One is red, one is almost dark with a white scaly thing. Both are psoriasis, but only thing, the picture on your left, this should be a white, and this is skin of color. See, that is the difference why we need all these integrated tools. See, those days, a person who's practicing in Chennai, it's enough if we know the diseases in our locality, what are the common skin presentations, common skin diseases, and all those. Now, world has become very small. So we do have a lot of people in my own practice. I see Koreans working here. I see Japanese working here. I see Nigerians coming to my clinic. I see British people coming over here. So for different people, the skin lesions will be different. They are what do you call in their area, certain infections can be common. For us, skin malignancy is relatively uncommon. For them it is a very, very common thing. In England, if you're going to have a skin lesion, the first thing they would like to exclude is a malignancy. For us, that comes after excluding our usual conditions. So it is very, very important for us to know all the diseases, irrespective of the area where it is prevalent. And this is how the whole morphology, that is the structural appearance, changes in whites and skin of color. So the factors influencing the skin appearance, melanin and globulin, hemoglobin, Melanin, we have seen hemoglobin, we do see in our blood. For some people, we see the face is very red, isn't it? That reddish color that comes because of the vascular means the blood vessel, the hemoglobin, which is inside the blood vessel, that gives you that reddish hue or that pinkish hue that certain people have in their face. So these are the two things which are going to determine the baseline color, pigmentation, and vascular tone. Then comes your age. So from a baby to a person who is in their 80s, the skin is not the same. As you age, the dermis, that is the middle portion, it thins down, the collagen reduces, and so you know why so many people are promoting collagen for anti-aging, and there will be a slower turnover of cells, which is going to cause you wrinkles, dullness, and altered reflectance. And then the climate and environment. A person who's exposed to a lot of sun, like maybe a farmer by occupation or person who is almost outside, these people, if you see, the skin is entirely different, and the humidity of the area, the temperature effect, everything will be there. Everything will change the appearance of the base appearance of the skin, and hence the appearance of the skin lesion. Skin appendages, the hair, sweat, and sebaceous glands, they modify surface shine, pore visibility, and image contrast. And then again, the site. See, if you're going to take the palms and soles, the lesions are going to be entirely different. The skin is different. The color of the skin is different. That's not going to have any sweat glands, oil glands, or anything. So these site. See, why I'm insisting on all these is when you see a lesion where you suspect a cancer or precancerous, we have to take all these things into account. So, evolution from clinical diagnosis to evidence based precision. Uh, Hope I am audible. Yes?
Yes, ma'am, it's audible, ma'am.
Yes, ma'am.
Yeah, thank you. So, evolution from clinical diagnosis to evidence based precision. So, for us dermatologists, we also always joke, if you're not able to diagnose at the first shot in few seconds, then you really don't know the diagnosis and you got to work on it. And then, apart from this clinical examination, we then started having dermoscopy, which is a non invasive imaging, a very small clinical equipment that we have. And then came the confocal microscopy, and then the spectroscopy, the Raman spectroscope, then the histopathological correlation, which I told you, taking a skin biopsy, and now it is going to evolve into digital and evidence based dermatology. So apart from that, other ones are your optic coherence tomography, and then your high frequency ultrasound. For sometimes you have a small swelling in the skin. You do a high frequency ultrasound, which is going to give the superficial data very clearly, the skin level data very clearly. And then your deep learning models, image analysis software, and now there are a lot of teledermatology platforms. Before COVID, all these teledermatology was not approved by a government. In fact, we had a lot of legal issues doing it. And post COVID or during COVID itself, all these teledermatology was permitted by the government, and hence it's becoming a common practice these days. So clinical, of course, by inspection, touch, history taking, we need a lot of elaborate history taking. And normally you see in a dermatologist office, you see a magnifying lens, which helps us in a lot. And then the Woods lamp that you see here, right? The Woods lamp, glass light pressure test, that is your diagnoscopy, torchlight is integral part of our examination. And then we have small side lab procedures like Zang smear, QH mount, and gram stain. So this is the dermoscope. So coming to dermoscopy, in 1655, Pierre Borel was the first person who introduced this basic principle of dermoscope and gave a very rough early version of it. And then Paul Gerson Unna, he developed something called as diascopy. And in 1922, Jeffrey Michael, a Houston dermatologist, he adopted this dermoscopy seriously. And in 2001, almost after 80 years, a company called Dermlight got their patent for this dermoscope. So this dermoscope, this is a normal digital dermoscope that you see here. There are some advanced version which gives a video dermoscopy option as well. where you can do sequential imaging, and there are something called as ultraviolet or fluorescent dermoscope. And now two main companies are dominating in this field. One is Dermlight, the second is Heens. And of course, now we have got a lot of Chinese products coming. All these, what I told you, the Dermlight, Heens, costs about 1 to 2 lakhs, depending on what specification you need. And the Chinese versions are available now at almost 1/3 or 1/4 the prices itself. So this dermoscope, we have got a non-polarized and a polarized option. And apart from that, I told you a wood lamp, isn't it? This wood lamp version is also now available in the dermoscope. And this non-polarized, we use it mostly for superficial structures. So we here definitely there should be a interface which is usually a glass plate or sometimes a liquid like oil or maybe water. Here, what happens? The surface reflection will be more. The superficial structures are detected very easily with the non-polarized dermoscope or non-polarized version in the dermoscope. And in the polarized version, the deeper structures are seen better. You can see here the black one, that is the superficial depth. You can see the epidermis very nicely in non-polarized settings, and in polarized it is the deeper, a little dermal lesions can be seen better in this polarized one. So you can see the difference here, the non-polarized versus polarized. Non-polarized, morely the superficial epidermal structures are seen clearly, they are magnified a lot. Whereas in polarized, if you see the deeper structures, whether how deep the pigment is or whether there is any vascular changes beneath, those things are seen in the polarized setting. Then briefly, this confocal microscopy, the reflectance confocal microscopy was the lot of importance was given to this. It's basically light illumination through a pinhole. You get a 3D view of the lesion there. So you see the skin over here. So what happens is from the laser light source, laser which is the light source, the laser waves, it travels through the objective lens and the pinhole. So what happens? The light only on the focal plane will enter it. Rest all are cut off. So, and then slowly the spot is moved across the tissue at different points. Completely, it is completely done. It is just moved across the specimen to scan the whole area. And now the complete collection of these 2D images in different focal planes is made, right? So it's just along the focal plane alone, the light falls here, and then you get a 2D image of this. Now, what we do, we have got a collection of 2D images. Now, a 3D reconstruction is done there because at different planes, you're going to do that 2D image. So you get a 3D reconstruction, and that is confocal microscopy. Here, the advantages are, it's of course a 3D reconstructed image. And second, the contrast and resolution will be excellent here. It's very precise, it is excellent, and the optical sectioning is done. See, in the histopathology, normally when we do a biopsy and take a tissue like this, we make sections like this along the coronal plane, along the axial plane, and then we study at different levels, especially when it comes to malignancy. So the same optical sectioning is possible in this confocal microscopy, and the lighting is also uniform. There is a standardization there, but the problem is the expense involved, and it is a big setup. Not all places can have this confocal microscopy. It is an investment, and you need a resource person, you need a expertise there. And another problem is with these lights, there's a lot of photo bleaching of the tissue. So that is with reflectance confocal microscopy. And then we have this Raman spectroscopy. So this is based on inelastic scattering of light. That we know the Raman effect, where the laser light, it interacts with the molecular vibration, producing unique spectral fingerprint. It's usually called as the chemical fingerprint of the tissue. So the vibration of molecules like lipid, protein, and water, this is studied. So this is very important in differentiating between benign and malignant lesions. All right, especially in melanoma, Raman spectroscopy is talked about. And I doubt if hardly two, three centers in India would have this Raman spectroscope in hospital setup or in a pathological lab setup. So now, so see, all this time we had been talking benign, malignant, benign, malignant. So you should know that benign lesions are non-cancerous. These are very slow growing, or sometimes it just appears and it doesn't grow. And this is harmless and painless. Whereas malignancy means cancer. It is fast growing. So what is the problem? It's going to spread elsewhere in the same site, or it can spread through the blood, through the lymph, depending on the type of malignancy. It can bleed or it can change shape. So the small benign lesions, your acne is a benign lesion, your pimples, your skin tags that you have in your neck, the red spots that you have in elderly people have, that is the cherry angioma. Then these sun things like freckles, lentigens, old people having this seborrheic keratosis, the nevus mole. These are all benign lesions, which is harmless. You need not worry about them. These are not going to turn to anything disastrous. And then there is a pre-malignant condition, especially I'm talking only about pre-malignant conditions pertaining to melanoma because that is the topic given. So there is something called as pre-malignant condition where it is not malignant at this point, but it can turn malignant and at any point of time. So this needs constant follow-up, right? You see a small lesion over here. This looks almost uniform, nice. But when you have an enlarged dermoscopy, you can see the irregularity in color and you can see the margin. The margin is not very clear and precise. You can see some small extension across the margin, right? So this is a dysplastic nevus or Clark's nevus. So for this, either you have to remove it immediately and send it for biopsy, or you have to wait, keep following up the patient and tell the patient, come on, now it's time, you have to go for biopsy and get it checked. That follow up is necessary in these cases. And then a normal melanocytic nevi, that is at birth, some people have moles, isn't it? That when it is a giant one, when it is a bigger one, we need to be worried. For some people, the melanocytic nevi, it is very big. Almost the whole trunk may have that black patch. So those giant melanocytic nevi, they are more prone to turn into malignancy. And the normal nevus only, the normal mole that you call it in layman's term, if there is change in surface structures, if you feel it is getting crusted, it is getting withered, it bleeds, it hurts, then it is an alarm sign. It might turn into malignancy. So if you see here, there are many findings here. Later as we go, I will elaborate on that. So these are pre-malignant, that is, it's not yet a cancer, but it is going to get converted into a cancer. Again, this is a small spitz nevi. This also looks very benign, right? It looks very benign. But when you see the dermoscopy, look at these structures, the pseudopods, the leg-like false structures, the pseudopods, and the pigmentation. See, this is why we need your technology. We need data. We need compilation of data. These are small things which are not visible to the doctor's eyes. So malignancy, yes, there are three malignancies. Leave this keratocanthoma. This is a border between pre-malignant and malignant. But the most common things that we see are basal cell carcinoma, squamous cell carcinoma, melanoma, and the lymphoma that happens in the blood and lymph node can happen in the skin as well. So melanoma is not a very common condition in our skin, in Indian skin. Ours, the most common is basal cell carcinoma, and then comes your squamous, and then comes your melanoma. Why was I talking a lot about sun exposure and all these? Take it from me. All these malignancy, especially the basal cell carcinoma and melanoma, they are mostly seen in sun exposed areas. Constant UV radiation induced DNA effects can change a normal skin into cancerous skin. So that is why the sun exposure is vital, and tanning helps protect us from skin malignancies. So when you come to a lesion, a small, what do you call, a papule or nodule in the skin, You have to look for certain signs for malignancy. One is asymmetry. See, this is a benign lesion, this is a malignant lesion. Look at the symmetry, it looks the same, right, throughout. Here, it is asymmetric, it doesn't look the same. And then the border, whether there is a even border, whether there is a well defined border, or is it zigzag, is it crusty, notched, irregular, extending on one end. So this border is important. Third, color. If you see the previous slide, look here, it looks almost the same color. But when you enlarge and see, you can see the color variegation. Different colors are seen, right? You see a purplish color here, you see a brown color here, you see a pinkish color, you see a blackish color. This color variegation also denotes malignancy. And anything that is white or blue, it is a red flag. That's bad. You have to be cautious there. Then the diameter. Okay, so as the lesions become bigger, see, some people will say, Doctor, I had this mole from earlier. Now I feel it is growing. Then, yes, it is an alarm sign. You have to look for any malignant change. And it keeps evolving. From a small mole, there might be a change in size, shape. As I said, the surface changes, like it gets crusted, a scab forms, or it bleeds. It keeps evolving. These ABCDE are very important when it comes to skin malignancy. Then there are some melanoma mimickers. See, all that is black is not melanoma. Of course, melanoma can also come in white color. We have something called as amelanotic melanoma, where melanoma looks in skin color. Okay, so usually melanomas are dark, and all dark lesions are not melanoma. You shouldn't unnecessarily may get the patient stressed and run for a investigation and all those. You should know when to interfere and take action. So this I told you, the amongst the benign, I told you something called a seborrheic keratosis. Most of the elderly people in a house, or parents or grandparents, will have this, especially over the face, scalp, uh, back, chest. These are the most common sites where you have the seborrheic keratosis. So this will mimic a melanoma, but again, it is the dermoscopy which will help you differentiate between a melanoma and a melanoma mimicker. And sometimes basal cell carcinoma, I told you three carcinomas, right? So this basal cell carcinoma, there is a pigmented variant which will mimic a melanoma. Okay, why is it important? Basal cell carcinoma will only spread horizontally or maybe a little deep. It will never invade the blood vessel or lymph node. So, if at all God has destined you to get a cancer, then let it be basal cell carcinoma, because this is very much treatable and doesn't spread anywhere. Whereas the same thing, if this is a melanoma, it will invade, it will enter the blood and go and settle down in different tissues and cause a spread, metastasis or secondaries. Okay, in melanoma you have something called as skip lesions, because if these cells, malignant cells, the cancerous cells, they'll enter the blood vessel and get deposited somewhere. So it is very important for me to say, though it is a skin cancer, whether it is a basal cell cancer or whether it is a malignant melanoma. Okay, so that is why when you go for a enlarged dermoscopy picture, you can see a lot of changes in a basal cell carcinoma. This is very important, because if I'm going to just remove it surgically, giving it a clearance, that is enough for the patient. I need not do anything. Whereas when it comes to melanoma, I have to give chemotherapy, I have to go for complete excision, I have to look for the lymph nodes, and then I have to go for a chemotherapy as well. And in dermoscopy, if you see, there are a lot of patterns which need to be studied. Just imagine how difficult it is for all of us, right? To have these blood vessels, these spots, dots, larger dots, all these thicker lines, hairpin bend like blood vessels, and all this serpiginous pattern, loopy pattern, and all those, right? It is very difficult for us to have track of things. See, for example, I'm following up a patient. I need a track, right? So for it is there where this compilation of data is important. And there, see what was there last time, is it the same this time, or some other extra progress has done. For all these, we need some data compilation and comparison where your technology is going to help us. So as I told you, in dermoscopy, all these patterns, network pattern, whether this network is simply patchy, whether the network is only in the periphery, whether if in the periphery it just has a central hyperpigmentation or central globules, or is it only these globules there, or these globules are very big like cobblestones. See, this is very, very, very vast topic. I put it as simple as possible to you all. So it is very, very vast topic, and it is very difficult for us also to have track of all these things. See, I see a patient today. I have to follow up the patient after 3 months. How will I remember what were the changes and where exactly were the changes, unless and until I have a proper documentation, size wise and site wise, right? So, so many different what do you call datas are there which has to be picked up and compared. And these are the things which I told you. We, you remember, we saw the Spitz nevus having all these atypical, all these streaks around. So there, sometimes you have atypical streaks. The same thing, you have some atypical streaks. Now, oh my God, that's not Spitz, it's melanoma. So that will be the alarm signal for me. If I just see through a lens, probably only this and this I'll be seeing. I need a better software to have a better visualization. And for comparison, maybe 1 month back it was just simple streaks, and now there are some atypical lesions here. So that is a red flag for me. So these types of vascular patterns have to be fed into the software. See, these are the things which has to be compared. And when you come to melanoma, there are different types. There is a superficial spreading melanoma, a lentigo malignant melanoma, a nodular melanoma, acral lentiginous melanoma, and a um, melanoma which is amelanotic as well. That is, there is no pigment there. All right. So what is the difference? Why should I? It's all melanoma. It is all skin cancer. Why should I have all these difference? So if I say it is superficial spreading melanoma, it implies that it's not going very deep. It is only a horizontal spread. So if I'm planning for a surgery, then probably a simple clearance is enough for me, right? Whereas if it is a nodular melanoma, and even if it is a small nodule, I understand that the cancerous cells are going deep inside. So it is going to invade the blood vessel. It is going to spread to the regional lymph node or the next organ which is nearer to it or even distant to it. See, melanoma, I recently came across a patient who was working in a young female, say in her early 40s, who's working in IT. She came or she was referred to me for some other skin issue. So this lady I was seeing, she was undergoing some anti-cancer therapy and all those, and surprisingly it was a melanoma. And I asked her the history. She was saying that the melanoma was there in the mucosa, the anal mucosa, which obviously was not noticed at all. And she presented only with these secondaries in her lymph node in the inguinal area, that is the hip area. There alone, she had a pain. And then, as she went to investigate that, thinking it's appendicitis or something, then they told that no, no, it is a metastasis in the lymph node. Then they had to search for the primary melanoma, which was silently sitting inside the anal, rectum. So that is how this melanoma is very, very important, right? Then the lentigo malignant and acral lentiginous. Acral means in your hands and legs. That is the fingers and toes or palms and soles, right? Acral lentiginous. And then, as I told you, the amelanotic type, where there is not going to be any sort of pigmentation. Okay, it's just going to be a skin colored bump. So this is an acral melanoma. I can see this, right? This is an acral melanoma. The pigment globules will be seen in this. Okay. So we have to look for all these signs when it comes to melanoma. A blue veil, multiple brown dots, pseudopods, radial streaming, scar-like depigmentation, peripheral black dots, globules, multiple colors. broad network, sharply cut off border, and negative network and irregular vascularity. I'll show you here. This is a blue veil. Okay, things are not as easy as we see in textbooks. In practice, all these are very, very, very vague things where you really have to have an idea before you see the proper dermoscopy. These are the atypical globules and dots. You can see each one is of different sizes. It's not uniform. And this atypical streaks that we saw there, right? It is not the same. You saw the spitz nevus. It was very uniform. This is very different. It is atypical. One area it is clubbed, one area it is thick, one area it is thin, dull. So these are the atypical dots and negative network. That is normally our skin has some ridge pattern, right? That will be seen in white color. That is the negative network, and the atypical reticulate pattern, a net-like pattern here, right? Angulated lines, granularity. This is a scar-like depigmentation. You just see a white area. And this is the blue whale, as I told you. Again, not always do we see such clear pictures. And that too, since it is a white skin, you can see this blue whale beautifully. If it is a dark skin, this is again going to be a big task. Again, the negative network where you see the reticulate pattern as white lines, shiny white lines that you see here. Then the blood vessel, you see these vessels, right? You see all these data that I'm producing, it's all white skin. If you just see this, none of it is brown skin. It is all white skin. That is the problem here. Again, the melanoma can also come to nails. See, there is a WhatsApp message which says that a pigmentation in nail is a melanoma, and this somehow circulates once in every 365 days. I don't know the logic behind it. And once this WhatsApp circulates, then I have a trail of patients who come to just verify whatever nail pigmentation they have is not a melanoma. So even a trauma to an injury into the nail can give you a black spot. Sometimes it can be a simple nevus. Then, of course, comes the nail melanoma and other fungal infection. But as you see in nail melanoma, pigment variegation is there. There is a dark band, and you will see some pigment variegation here and there, and you will see the pigment going to the skin also. You see here, the pigment is going there, and you can see different colors, right? So this irregular pattern indicates a melanoma. All right. And you can see the pigment going to the skin there. Skin either in the size or here or sometimes in this area as well. So that also indicates it can be a melanoma. So as I told you, melanoma can occur in the skin, it can occur in the nail, it can occur in the mucosa, that is the oral cavity or anal cavity. And then you have the stages of melanoma. So it can be confined to the epidermal region of the skin, right? This is the epidermis, if you remember it. This is the dermis, and then comes a fatty layer, the hypodermis or subcutis. So stage 0, if it is just in the epidermis, that is the superficial epidermis, right? Stage 1, it's in the skin and it's very thin. It's only in the superficial layer alone. Stage 2, you have a still more bigger lesion where it just juts out of the epidermis, trying to enter into the dermis. And then the stage 3, when it enters the dermis is the part where you have the blood vessels, lymphatics. So once it enters dermis, it's sure going to spread to regional lymph nodes, and can from the blood vessels, it can even go and metastasis anywhere, to your brain, to your liver, anywhere you can get it. And stage 4, when it has spread to other organs. So this is these are the stages in a very, very, very simplest form I have given you. So why am I worried, or why am I pestering you with the stages? Because when it is in situ, when it is in the stage 0, in the top layer alone, your 5-year survival rate, that is the chance that the patient will live for next 5 years, is going to be 100%. Whereas in stage 1 and 2, right, in the epidermis, then it is 97.6%. And down the ladder, if you see, if it is going to be stage 4 distant metastasis, it just 16.2%. That is 16% in every 100 detected person in stage 4, they are going to cross this 5 year. Of course, we have got a lot of new treatments, but this is the basic truth. The treatment is also going to be difficult. It is also going to be a little strong when you go down the ladder. So it is always important that you catch the patient in this stage itself so that you promise 100% 5 year survival for these patients. So where do I need help? I gave you a list of things we got to see. See, this is not a complete list. This is for your basic understanding. So all these, there is no data here. There is no data in Indian skin or skin of color. So you have to develop smart systems and machines that can carry out tasks that typically require human intelligence. And then machine learning, it creates algorithm that can learn from data and make decisions based on the patterns. All these patterns have to be felt: the vascular pattern, the pigment pattern, the reticular pattern, everything observed. And it requires human intervention when decision is incorrect. And deeper learning, where you use an artificial neural network to reach accurate conclusions without human intervention. So the same thing, the AI, it just has to mimic our cognitive function, and then machine learning should be there and the deep learning. So got to have image acquisition. See, whatever images that I have, there is no common or a national library kind of thing where you have all these images stored. So image acquisition is very important. High quality dermoscopic or clinical photographs, I wouldn't say or, and clinical photographs should be collected under standardized lighting, at least in educational institutions or tertiary level or quaternary level hospitals should have this facility, and there should be a database for this. And then pre-processing, you have to do some moderation for this, because you have to improve the accuracy. So based on the color, based on the age of the patient, based on the skin color, based on the hair, everything, you have to make some pre-processing so that the accuracy improves. And then expert dermatologists, here it is both the technical experts and the clinical experts, they have to sit together. They got to annotate lesion boundaries and diagnostic categories. It's something this data labeling needs expertise from both ends. And then model training, convolutional neural networks, they learn patterns differentiating benign versus malignant lesion. And then you have to validate it. Any research or any study without validation is useless. So accuracy is only tested on unseen images. You got to validate it multiple times. And these are the AI models that are used in dermatology: this convolutional neural network, segmentation models, hybrid models, and transformer-based models. So the CNN, there is a convolutional neural network. They just classify images and they try to give you a diagnosis. Whereas when you come to a malignancy, say a melanoma or a basal cell carcinoma, you have to identify the boundaries. See, as I told you, all these small lesions, you just do an excision, that is the removal of lesion with an adequate boundary. So, how do you understand this boundary is enough or not enough? See, these days, what we do is we do a frozen section, that is on the table itself, on the surgical table itself. There will be a pathologist available inside the theater. You take the biopsy, and then the pathologist there, they process it then and there and tell you, no, no, this side, right side, top, this point, there is some more malignant cells. You got to give a little more clearance there. So this will be a pathologist in the theater working hand in hand to uh, fix the boundaries. So this can be done with the AI model. So this segmentation model will identify the lesion boundaries, and in outlining tumors, this is again very important to prevent recurrence at the same site or metastasis. Then hybrid models, as I told you, just the image alone will not help you. A patient data, what is the age, what is the ethnicity, what is the site, what is the duration of the lesion. Say a lesion which appears in 1 month is not going to be the same as it looks after 4 months or 5 months down the lane. So you have to combine these data together and give a risk prediction. Say this person, age 70 years, has got this lesion here. This doesn't look like a malignancy, but probably I can give a risk prediction of so much percentage that it can change into malignancy given other parameters. So that is hybrid model. And then a transformer based model, it's a next generation level, learn long range patterns. So clinical analogy, a CNN, it looks at a lesion like a dermoscope, zooming into tiny pigments. Okay, so as I told you, there are so many pigment or so many vascular spots or markers that is identified. So this CNN looks at these lesions at a elaborate manner. And then the segmentation, as I told you, to draw the borders to decide on the clearance given in by the surgeon. And a hybrid model, it thinks like a clinician. So we have to, this machine learning, it's a traditional AI approach where the system learns patterns from handcrafted features chosen by experts. So I'm going to tell you, see, this is a U loop, this is a screw pattern, this is a thin vessel, this is a brush like blood vessel. I am going to give you some inputs, those based on these images, and those will be compiled, and so many experts will be there, everybody will give their inputs, and that has to be stored and processed. And then the algorithms, they analyze the lesion color, as I told you, the ABCD of these lesions, isn't it? So those, and so it works best when the features are very clear and structured, the melanoma versus nevus using ABCD parameters. And this requires both dermatologists and engineers to both give their input to define what features matter. See, for our skin, vascular pattern, to be very honest, is not going to be very clear because we are skin of color. So for us, the pigment pattern will be important. And this pigment pattern also, it is going to be difficult for us because already we are pigmented. We have to look at some intricate changes there in the pigment, right? And deep learning, as I told you, in pixels, you're going to study in pixels, which obviously we can't be doing as human beings. And you study it at multiple layers, and all the complex features are taken. Sometimes certain features which we as clinician wouldn't have picked up can be picked up by this deep learning process. So this is going to mimic the visual cortex. It is going to learn the edges, textures, patterns, types of lesions, and all these. So as I see this, I just see a big lump with a small crater there. That's all I see. But the CNN is going to look at, see where is the pigment, how is the edge, is this area, is it extending here, is it how thick it is, and all those. And then it is going to give you an answer. Most probably this is so. So this dermoscopy pattern is what the language AI is going to learn. Again, all these things we have already discussed. So this journey from benign to malignant. See, as I told you, there is no, only in very established cases, we can for sure short say clinically, yes, this is a malignancy, go get treatment. Sometimes it is a serial follow-up, charting the changes in pattern, the pigmentation, borders, surface irregularities. All these have to be documented properly. And you have to find when is the time to raise the red flag and decide on the time of intervention. As I told you, an early intervention is going to save your life. If you lose on this, then it's going to cost you a life. And then again, where to take a biopsy. You see a lesion, not all places in the same lesion is going to give a typical histopathology, that is cellular architecture of malignancy. So to decide, I have a lesion which is say 10 centimeters. Okay, so where am I supposed to take the biopsy? Am I supposed to take it at the center or the edges? Where am I supposed to take? For that, all these data and AI will help me guide the site of biopsy. And I would personally prefer this histopathology data, that is the biopsy that you take, the tissue that you take that is processed and cellular data is studied, right? That data, along with the clinical picture, along with the dermoscopy, all these put together should be integrated into a software for a better understanding and for a better predictability of all these AI tools. So the same thing again. So there's again now the explainable AI in dermatology is XAI, and that includes all these saliency maps, GradCam, where they are going to generate heat maps. Okay, and again, this is very important to differentiate between benign and malignancy. So this is the heat map generated, and then the clinician reviews it and then decides whether to take the biopsy or not. So where is the bias? As I told you, all these pictures that I have given is all in white skin. So for darker tones, see, we do have video dermoscopy. We do have softwares in dermoscopy, which when you take a picture only, the dermoscopy will tell you whether it is a malignancy or not. But that is all programmed only for the white skin. For the darker skin tones, we don't have a model, and that is also the most difficult part of it. And the and there is no standardization, right? The imaging device, one will use dermlight, one will use Hain, one will use a Chinese, the lighting, the patient population, everything. There is no standardization that can reduce the performance. So, and you cannot generalize a particular finding. See, this finding will be this, that sort of generalizability may not be there. And ensuring diversity in training data sets, as I told you, the lesion types. Always, when you again see, when a thicker lesions, this dermoscope might not be the right thing to do. In a thinner lesion, dermoscopy will give you more inputs. So all these should be brought into the concern. So AI tools are now being embedded into dermoscopy devices. AI not only classifies, may predict outcomes, metastasis risk, say this finding is there. So there's so many percentage of chance in metastasis. Metastasis means spread to other organs. So teledermatology platforms are also now present. They use AI for pre-screening. See, we do get a lot of, in Rilla Hospital, do get a lot of people from the Middle East, from Africa, from Britain, from Australia, anywhere across the globe, we get patients. So all these patients, sometimes what they do is from there, they just fix a teledermatology appointment, and then we see the patients. And if we feel, yes, I need to do a biopsy, I need to do something, yeah, you come, and then they'll come. Sometimes we'll see the patient and send them. Then they'll say, doctor, I need a follow-up. So for all these teledermatology platforms have become very handy for us, and there is an importance for electronic health record maintenance, and this health record integration enables seamless storage. Okay, and AI can prioritize urgent melanoma suspect lesions for quicker appointments. Take it from me, healthcare is not as easy as in India abroad. Okay, ours is the most sophisticated, most comfortable system when healthcare is concerned. In clinics, it serves as a second reader, especially valuable for general practice. Continuous clinician feedback refines models and builds clinical trust. So, where is the challenge that have? Yes, in the bias, as I told you, the color, and then the data quality that has told, and this inexplainable AI and all these black box models, they make decisions without clear reasoning, and so clinicians are also hesitant to take that as such. See, if you have seen all these years, we have evolved a lot in radiology also. So in many places, when you take a CT or MRI, this AI generated report comes first, then only the specialist report comes the next day. So the reliability of these reports, that is the problem, right? And again, if there is anything going wrong, then who is to answer this? Now, who is to face the medical legal issues? And then the data privacy. So you enroll your child in a school, your data is going elsewhere. You enroll a child for JE or NEET, the data is going elsewhere. So data privacy is a major concern when it comes to our setup. And clinical integration, the limited interoperability with electronic health records and need for real world testing before it's just rolled out. So false negatives, if you're going to miss a melanoma, then it is a serious medical legal issue. And false positives, unnecessary biopsies, patient anxiety, increased cost. See, I'll tell you, false positives are always better than these false negatives, because false positives only this money and stress is there. When it is false negative, as a doctor, I'll tell you, this will give me a lot of medical legal issues. You missed out, so that's why this happened. you have to face the consequences. So that is the limitation the current system, and need to manage the expectation. People have to understand both on clinical side and common man that AI is a tool and is not an independent decision making body. So all these we have already talked on, and the communication barrier between the technical experts and the dermatologists, I think that's a big gap. Who's going to uh, bridge that gap? That's a problem. So what's it going to be in the next 5 to 10 years? Routine screening in primary care, telederm with AI triage, and refer to dermatologists for flag lesions. Take it from me. Tamil Nadu has got the most beautiful primary healthcare system. So somewhere somebody is in a very remote village. If the patient needs a dermatological intervention, all these might come into play. AI enables smartphone apps for patient self monitoring of suspicious lesions. And this is again a very risky one. You know why? And hybrid models combining imaging, genomics, pathology, risk assessment, and all those. And see, this is a continuous learning system. Though we are giving some input and you're developing something, and as we again go through a lot of new pictures and new photos, new clinical data, new dermoscopic data, it's a continuous learning system. This keeps evolving, getting better day by day. And there is a re-refined role of dermatologists, and we can focus more on complex decision making, intervention, surgical intervention, patient counseling, while AI just supports in this triage process. So conclusion, bridging human expertise and AI, that's the most thing, the need of the hour. So this, as I told you, has I repeated n number of times, to raise red flags, this is important. To improve the biopsy accuracy, the site of biopsy, the timing of biopsy, AI is important. And to address this gap in whites and skin of color, it is important. And it enables longitudinal lesion tracking. That is the follow up of lesions. Say I treat a patient, I send them back. Okay. Say a melanoma patient, they come to me, I treat them, I send them back. I have to monitor these patients, right? So, in all these, this technology helps a lot. And there's a large space for a lot of research in this field. So, future of AI into clinical workflows for decision support, education, and management. Thanks a lot. I hope I have done justice to the topic. Over to you, ma'am.
Thank you, ma'am. Participants, you can post your questions and doubts in the chat box, or you can unmute and ask, ma'am.
Ma'am, is it transferable to any other person from one person to
No,
another
no,
person?
no. No, 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 no. Cancer is never contagious. Only
Okay.
infections are contagious. Allergy or malignancy cancers are not contagious.
Thank you, ma'am.
Any other questions from participants?
Ma'am, actually, I was working on this data last.
Pardon?
Yeah, actually, I'm working on this skin disease.
Okay.
Uh,
Anything
when I-
specific, sir, or as a whole?
uh, yeah, I'm having a data. I just got a data set, public data set. The data set consists of 7 classes.
Mm-hmm.
So when I'm training my custom model, CNN model, actually I'm not getting that much good accuracy.
Okay. May I
Um,
ask you from like data set is of data from which country or which area?
it is abroad, ma'am. Ham data set, Ham
See,
10,000
see,
data set.
see, that is the problem. See, there are some video, higher end video dermoscopy softwares and everything which has this AI imbibed in it, which gives the diagnosis also, but that doesn't work in our skin, sir. This is a totally different genre.
Okay. But on that data set itself, I'm not getting that much. But there are some reported papers are there. So
Mm-hmm.
they are mentioning 90% and 92% like that. But when I'm
See, these data sets are of clinical images or dermoscopy images.
clinical, I think so.
Okay. See, that is why dermatology is very difficult. You need a lot of, you got to see your eyes naturally gets trained after a long period of time, sir. Your eyes get trained to pick up all these small, small things.
Okay. Thank you, ma'am.
Yeah, to Miss Dolly Iron, yes, ma'am, melanoma affects skin specifically. Melanoma is basically a malignancy of the skin. As I told you, these coloring cells are present in the skin, hair, eyes, and part of brain as well. Okay, so leave alone hair, the rest of the areas, anywhere it can come. The most common melanoma we see in the skin only. And as I told you, this melanoma cells, that is the cancerous cells in this melanoma, they try to enter into the blood vessels. So that is why I told you early, if you catch, you can just what do you call, pick it before it enters into the blood vessels, and hence this spread to different other organs can be avoided. So if it is a localized lesion, a small skin lesion, it is easier to treat, right? If it is going to some other tissue and everything, then you have to go for a chemotherapy, biologicals, and there's so many other things involved. Any other questions?
I think there are no more questions, ma'am.
Okay, ma'am.
Thank you so much, ma'am, for your informative session. Your
Thank
clear
you.
and simple explanations have enriched our understanding tremendously. And we appreciate the time and effort you took to be with us today in spite of your busy schedule. And thank you for clarification. Thank you for your clarifications, ma'am. On behalf of all the organizers and participants, our sincere gratitude to you, Dr. Suganya, ma'am, for sharing your expertise with us. Thank you, ma'am.
Thank you, ma'am, for this opportunity, and it's a pleasure to share knowledge with you all. And I hope somebody picks on this topic and does something which will be really, really useful to our people.
Yes, ma'am, sure. Thank
Thank
you,
you,
ma'am.
ma'am. Thank you.
Thank you. Thank you, participants. Now let's move on to the next session of our FDP. Now I'd like to welcome Dr. Johannes Sam Attens, who is an assistant professor at the University of Catania, Italy. He earned his bachelor's and master's degrees in electronics and communication engineering from SSN College of Engineering, India, and received his PhD from the University of Catania, Italy. His research focuses on machine learning for infrastructureless and intelligent networks with applications in vehicular communication, smart mobility, and wireless sensor networks. He has contributed to several European and regional research projects, including Samothrace, Coglo, SafeDemon, Cycle Shield, and Delias, and has published in leading IEEE and Elsevier journals on topics such as distributed machine learning, intelligent transportation systems, and underwater communication. We welcome you, sir. Over to you now, sir.
Thank you, ma'am. Thank you for the introduction. Let me try to share the screen now. Can you see the screen right now?
Yes, yes, sir, we can see.
And I hope you can also see it moving. Okay. 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 Hello everyone. Good evening. It's still afternoon here, so anyways, I'm Jonas Samotans, and the title of my talk is Machine Learning Driven Healthcare in the Metaverse. And I'm here working as an assistant professor at the University of Catania in Italy. And today I'll be talking about how digital twin frameworks are developed in Metaverse. And we as a research group, we are working on this for past 15 to 20 months. And before I jump to the technical stuff, I want to show a couple of slides about our university and where I'm currently in. And also, this work is partially supported by the Samothrace project and also the European Restart projects. Okay, so and yeah, so I am currently in Sicily and in the city called Catania. And Sicily is beautiful and big. It's the biggest Mediterranean island. And as you can see in the second image there, it's in the southern part of Italy. And it is also home to the most active volcano in Europe, which is Mount Etna, as you can see in the first image here. So, and it also has the biggest university in the southern Italy, and it's a mega university. And Catania is an ancient city in the Sicily south coast, and the image you see here at the right hand, it is the main street in Catania, and you can see the volcano at the background. And the university here is the University of Catania, which is a mega university when you see it in the Italian scale. And it's also one of the oldest universities in the world. So it's like the 29th oldest university in the world, which was founded in the 14th century. And you can see our research group here. We are networking people, and we work on several communication topics, also in unconventional communication areas like underwater communication, intra-body communication, and also we are currently working on this healthcare and metaverse. And yeah, so I will probably jump to the technical stuff. So today I will talk about the role of metaverse and digital twins in healthcare. Why we go for a metaverse, and what are the applications and what we have developed in so far with our PhD students and our colleagues. So in that we will go in two specific areas. One is the development of digital twins in organ levels, meaning that we develop digital twins for organs, specific organs like heart and lungs or kidney. So in that case, these digital twins can help in analyzing those organs, doing diagnostics, monitoring it, and we also integrate machine learning in it. So, these digital twins that are, responsible for these organs also run machine learning, at the back end. So this can, help the doctors in, giving alerts or detecting if there are anomalies or even like forecasting the trends. And then we are also developing a digital twins in the patient level, meaning that we have individual digital twins for each patient. So and for example, in our daily scenario in the hospitals, if the doctor visits a hospital, and every morning, like, they go around and they do like a checking in each patient room, and they see if the patient is fine and what is the status, all these things. So when you have patient level digital twins, the doctor can, monitor all the patients from his or his own office. And when you do it in the metaverse, it provides an immersive environment of both the organ level digital twins, also the patient level digital twins. So instead of physically visiting the patient room, the doctor can just put his Oculus or the MetaQuest devices, and the doctor can navigate to the virtually into the patient room, and study or analyze the status of the patient and also the organs. And since we are integrating machine learning into all this thing, or to the digital twins, it's also necessary to see how the models are trained. We always see different convolutional neural networks. We see different types of models. We take data set from all online platforms like Kaggle, and we see do this classification, and we report the accuracy and all these things. It's nice to do all that, and it's good in research point of view. But how is it done in real scenarios? Is there a central server that collects data and does this machine learning, or is this done in a distributed manner, or where is this machine learning running? Like we run it in some Python code editors or like Google Colab, but how is it done in a real scenario? Like how is the machine learning done? So I will also talk about the machine learning for this kind of clinical applications, and how it's done in a distributed manner in hospitals, and also in this case, in the case of metaverse. And then finally I will talk about a resource allocation problem, because when we talk about healthcare, the main thing is these data are critical. So when you have to feed a real-time data when you're in the metaverse, when the doctor is analyzing the patient models, or he's when the doctor is looking at the animated models or of the human organs, real-time data is something very much important, because the doctor cannot be seeing a process that was happening in the past 3-4 seconds. The doctor has to be looking at the real time functioning of the organs. So the data transmission is something important. So when I say data transmission, it's from the sensors being deployed on the human body to the doctor. And this is an important problem, because there are bandwidth issues, there are network constraints in hospitals. So how the critical data is given importance for for the doctor to for the metaverse application, so the doctor can have a real time functioning of this organs, or these process. So we will actually see about this three categories of work. And okay, so first of all, why do we go for metaverse? There are it's a revolutionizing thing right now, and it's getting a lot of attention, even with the healthcare industry, the healthcare. So first of all, it provides a immersive framework, or like an immersive environment for the doctors or the physicians to do diagnostics, to do analysis, to do real-time monitoring, and so it provides an immersive, environment. Second is, in the current scenario, there is limited access to real-time clinical environments for the medical students. So when we develop this metaverse applications, they can have advanced immersive environment for their medical education and training. So there are like remote sessions in which the students can participate and get trained on it. And they can also do surgical simulations. So for example, if you do a task, like how does it impact on the human organ, what are the parameters that are getting changed. So you cannot be doing something like this on a real human body. You have to do simulations. And when you do it in an immersive way, it's very much advanced and beneficial. So this is a very important critical role that the metaverse plays in the healthcare, and also remote consultations. So for example, a patient can consult with a doctor from a different country, and the doctor can analyze the patient's organs from a different place. And also when you're in a metaverse environment, the doctor can prepare himself or herself for a surgery. For example, the doctor can analyze if a drug is injected, how does the human body change, or how is it adapting, or how are the parameters changing. So all these things can be done in an immersive way, and that's why we go for a metaverse and metaverse framework. And also you can interact with the digital twins. So when like I said, when you have digital twins for the human organs, the doctors can navigate to the heart organ, or let's say a kidney organ, and analyze it in an immersive way, so using this virtual reality. So, and like I said, we are also integrating digital twins. So, probably what a digital twins are. And here in healthcare, a digital twin can be for a patient, or can be for an organ. So, digital twins specifically for an organ. And also it can be specifically for a biological process. And today I'm going to be talking about both organ level digital twins and patient level digital twins that we have been simulating in our research group, and we have been working on it for the past 1 year. And why do we have these digital twins? First of all, so there are again a lot of advantages and stuff with this. So one is real-time monitoring. So when you have digital twins that are collecting real-time sensor data from the human body through probably a lot of sensors or wearables like smartwatches, you can have a real-time monitoring of the organs. For example, you have these days we have smartwatches like Apple Watch, and when we wear it and we go for jogging, and you can actually see what is your heart rate, and you can see what is your breathing rate, probably what is your blood oxygen. So you can monitor all these things. But apart from that, what if you wear a VR device like Oculus? And what if you can see your own heart beating while you're running or doing an exercise? This actually provides the immersive perspective, and this is something very, very important for doctors and physicians. So you can do real-time monitoring when you feed this sensor data, and you can also do simulation of behaviors and responses. So like I was already telling, so what happens when a drug is injected into the body? How does the human organs respond to it? And you can do the simulations in an immersive way. And then you can also the last point is integrating machine learning algorithms into the digital twins. So for example, when you're monitoring a real patient, and if there are irregularities in the patterns, for example, irregularities in the patterns of the heart rate, if there are any anomalies, these digital twins can alert the patient and also the doctor in hospital. So this is the one all the reasons why we develop digital twins, and it's something getting a lot of attention in the healthcare community. And this is one of our initial work. So we wanted to, develop a digital twin framework for human organs. So this is, in the organ level digital twins. So, as you can see in the image here, this is our, our scenario. So we have patients, and we get real-time data. So you can, have sensors, or you can, have wearables and like smartwatches, and you can get real-time data from the patients, and then you feed this data to digital twins. So, and these digital twins are for human organs. So I have a digital twin for for the kidney, for the lungs, or for the and I have a separate digital twin for the heart. So and for our work, we started with, the two critical or the two, main organs in our human body. So we had a 3D animated digital twin for a heart, and we had a 3D animated digital twin for the lungs. So what does this digital twin do? So, when the doctor wears the Oculus or the VR device, the doctor can actually see the real, the heart beating or pumping, or the lungs deflating and inflating in the VR device. So it's as if like the doctor is actually looking at what's happening inside your body, meaning how your heart is functioning, how your lungs is functioning, based on the real data, real sensor data that is fed from the sensors, or the wearables. Additional to looking at these 3D organs in the virtual environment, these digital twins also have machine learning that is running behind. So why do we have this machine learning? So I was talking about this in the past couple of slides. So the doctor will not be only visualizing the real time 3D movement of the heart or the lungs, but also when you have a forecasting model running, when you have a LSTM or a CNN model that is predicting this heart rate or the lungs breathing rate, the doctor can also see the future trends, meaning that additional to the real time view of your organs, the doctor can also see what will be happening in the future. So how will your heart be pumping? So when you feed also the future forecasted data, the doctor can also see how your heart will be pumping in the next 2-3 seconds. Of course, the doctor cannot see how the organs will be functioning in the, or be how the organs will be moving in the next 2 minutes or 1 hour. I mean, nobody knows that, but you can use machine learning to predict something that will be happening in the next few seconds. And so the doctor can not only have the real time view, but also a predicted or forecasted view of these organs. And this is our lab, and we have the PhD student working on this, and he's actually showing the 3D view of the animated organs, and to the master students here. So we have the MetaQuest device. So the student, the guys who are wearing the virtual device, it's the MetaQuest 2 device, and they are actually looking at the real time view of the heart organ. And this is from the smartwatch data. So and when the student wears the Oculus, the student can actually have a immersive view of his own heart organ, how it's moving. Like when I say moving, it's how it's deflating or pumping based on the heart data. And how did we do this immersive design? So we actually took shapes like heart and lungs shapes, 3D model shapes from Blender, and they were created in Blender software, and we imported it in Unity. Unity is a very useful tool for developing metaverse applications. So we, like I said, we first started with the heart organ and the lungs organ. So we developed this 3D models for the metaverse, for the immersive view, and we had data coming from both data sets. We also used a data set, and also we used data from the smartwatch. So, and in the Unity environment, we created pulsating animations. So the heart will pulsate based on the live heart rate. So from the breathing rate, from the heart rate. So that is the bits per minute. And we developed in the 3D models like 4 chambers, like the left atrium, right atrium, and the left and right ventricles. And when it comes to lungs, we designed the inflation and deflation of this lungs organs, and this will be inflating and deflating based on the breathing rate. And we use the MetaQuest 2 device, like I said. And what the user can do is the user can use the VR controllers, and the user can navigate, or position the organs. So then user in the immersive environment, the user can go near the heart organ, have a different view, position it, zoom, reposition those organs. So it's as if, like, you are inside the human body, and you are navigating inside the human body and having a view at your own heart organ or the lungs organ. And apart from the view, we were also giving colors to it, meaning that when there is an anomaly, for example, when the heart rate goes beyond a threshold, or when the breathing rate goes below a threshold value, you actually see a change in color. Also, the sound intensity changes, meaning that you when you wear the VR device, you also get the sound haptics changing. So you get maybe a different sound that will alert the doctor or whoever is wearing it. And also, if, for example, the doctor is operating, and the doctor is having this oculus, and wearing this oculus, and is injecting a drug, and suddenly, if there is a change in color in the organs, like if it is like in a red color, it means that something abnormal is happening. So this can alert the doctor, and it can prevent an accident. And like I said, we used a data set for all this machine learning task, but we were also getting real data. We used this app called Heartcast, and this is an app in the Apple Watch to get the heart rate data. And the watch will use the Bluetooth Low Energy to broadcast the Bluetooth packets. So it uses the standard Bluetooth heart rate service, which is a standard service in the Apple Watch. And we used a simple, Python script that uses this library called Bleak to, subscribe to this notifications to this Bluetooth packets. And there was a neural network running behind in the Python code that does training every 20 seconds, and it was a forecasting model, and it takes like past 10 values to forecast the next heart rate. So if you see in the slide here, the doctor will not be having just the real-time view of the organs, but also what will be happening in the next 1 or 2 seconds, thanks to this simple LSTM model that is running in the backend. And we also used a data set. This is not just for the viewing of the 3D organs, but like I said, we also integrated machine learning algorithms. So we use the well-known MIT BIH data set. Maybe some of you might have worked on this data set. It's a very popular data set, and the data were collected from 16 subjects while they were sleeping, from age 32 to 56, and it had many psychological signals. But we focused only on since we were developing 3D models for just the heart and the lungs, we focused only on the heart rate and lungs rate. Of course, there was only raw signals at 250 hertz, but we extracted, from the ECG and also the respiratory rate, we extracted the heart rate and the breathing rate. And we extracted it using some predefined Python libraries. And for example, you can see in the left side figure, you can see the heart rate extracted from 4 patients from the MIT BH database, and you can see the breathing rate from this in the figure on the right. And like I said, we integrated machine learning algorithms, so meaning that the digital twin of these organs will be running this machine learning models. And we went with the two simple models. So one was the autoencoder model. So if you have worked on it, you will know what an autoencoder is. Basically, an autoencoder is an unsupervised machine learning algorithm that learns the representation of the data. So in the next couple of slides, I'm going to show how it works. But basically, it has an encoder and it has a decoder. So it will learn the patterns in your data. So, autoencoders are, mainly for learning the patterns or the representation of the data. So once you train your model on on the normal data, and when you do the inference, meaning that when it is working in the real scenario, when you feed an abnormal data, it is going to show you that, there is an anomaly, because, the loss value is going to shoot up, and it is going to say that the pattern is, very much different from the patterns that was learned by the model. Okay, so this is something that is used in anomaly detection tasks. So we use this model because this is very critical in healthcare areas. So to detect the irregularities in the patterns of, for example, the heart rate or the breathing rate, and it will show anomalies if there is an anomaly. Next one was, we also used a forecasting model. So like I showed in the previous slide, so this will actually forecast what is your heart rate or what is your lungs rate, so that the doctor can have also the predictive view of the organs. And yeah, so this is how an autoencoder looks like. Okay, so it's again a deep learning model with neurons, and so it has this encoder, it has this compressed latent representation, and then it has this decoder. So you feed the sensor data to the encoder. So in my case, it is the heart rate data or the lungs rate, the breathing rate data, and it is fed inside the encoder, and then it compresses it to a compressed representation, and the decoder tries to reconstruct the data. So it basically learns the representation of the data. So let's say that I am actually feeding the normal data, and the model is trained on this normal data. Okay, and when in the real scenario, when there is an anomaly, like the heart rate is shooting up, or there is a the breathing rate is very abnormal, in that case this model will be able to detect it, because it will give a very high reconstruction loss. Okay, and then it is going to tell you that there is an anomaly in this pattern. So yeah, and also we set thresholds. So we set thresholds for the reconstruction loss here. So that is mu plus k sigma. So it is the mean plus the standard deviation of the data. So, and depending on the k value, you can tune the threshold. So if you have a very less k value, then it means the threshold is less, and it is going to show you more anomalies, so more irregularities. So you can set this k value depending on your requirement. And the autoencoder model will detect anomalies, and it will alert the user. So and we also had the LSTM forecasting model, and this takes like the past 10 values of the heart rate. So we downsample the data, so we have like you know one value for every 5 seconds. So when I say a length of 10, it means, the past 50 seconds of value to, the predict what is happening in the next 5 seconds. And these were some of the results we obtained. Of course, the model was, training better with good training and validation loss. And all on the right side, you can see the reconstruction loss here for a particular patient. And you can see, depending on the threshold you set here, how the anomalies will be detected. Okay, so, depending on the threshold, you will actually see, if there will be less anomalies or more anomalies. Okay. And with the forecasting model, we were forecasting both the heart rate and also the breathing rate, and you can see the true values. True values is the values from the data set, from the MITBH data set, and here the orange lines show the predicted value. And we were actually achieving good performance with both the forecasting cases. And this work was actually recently presented in the conference on intelligent metaverse technology and applications that was held in Croatia last month. And moving to the next topic, so this is, so far we saw about the organ level digital twins, meaning that, we had digital twins for each organ. So now we have a digital twin for, each patient. So, this digital twin can have will have 3D models of all the organs, and it will also have a specific model, for each patient. Okay. And when you have machine learning integrated with this patient level digital twins, one of the challenge is how do you do the training? Okay, so if it is a centralized one or if it is a distributed one. So the traditional case was the centralized one, meaning that all the digital twins or all the devices send the data to a centralized server where the models are getting trained. But the important issue with that is the privacy issue. Okay, because health data is very much important and it's sensitive data, and you cannot be sending it to different servers or not secured servers. So there is need for privacy preserving solutions. So, and one of the well-known privacy preserving technique for collaboratively training machine learning model is the federated learning technique, that was proposed by Google. And Google proposed it in 2017. And the paper, I have listed it below down here. So Google proposed this technique, and it works very in a simple manner, meaning that you have client devices that runs the model, that has the model locally, but instead of sending the the raw data to the central server, it sends only the model weights to the central server, where they get aggregated and the complete model parameters are sent back to the devices. So in case of the healthcare scenario, this is a very good technique, because the raw data doesn't leave the client devices, meaning that when I have sensors or smartwatches in the edge, the models are also in the edge nodes, and the data doesn't leave the edge nodes, so only the model parameters are being exchanged. But there were also some issues with federated learning. The issue was that when you have federated learning, you send model parameters, but when you send model parameters, there are like attacks, security attacks, like GAN poisoning attacks. So GAN poisoning attacks are when GANs are generative adversarial neural networks. So these neural networks can take those model parameters and it can generate poisoned data. So there was this technique called split learning. Okay, so it's like federated learning, but it's completely different. And this was proposed by the team at Massachusetts Institute of Technology, MIT. And what they proposed was splitting the neural network and training between the client nodes and servers. And this was mainly proposed for healthcare scenarios, because this will avoid all this GAN poisoning attacks and all these attacks, because you have a partial neural network in the client side and you have the partial neural network in the server side. So only the activations are being exchanged, not the complete model parameters. So in this way, even if an attacker attacks the link, you cannot actually generate data with with those activations. So this is more secured, but there are also downside disadvantages of it, meaning that it takes it consumes a lot of communication resources in back and forth exchanging activations. So I will just briefly explain the split learning in just a couple of slides, and then I move to the work which we did with comparing federated learning and split learning for our scenarios. So this is a hospital scenario. So when you want to collaboratively train models between hospitals, so there is hospital A, B, and C. Okay, so the neural network is split. So when you talk about convolutional neural network or long short-term memory neural networks, so the neural network is split between the hospitals and the servers, and you do not send the model parameters, you do not send the raw data, you send only the intermediate representations, meaning only the activations functions. So this is more secure, and because the sensitive data doesn't leave the hospital. And this was developed for the reasons that patient data cannot leave the premises because it's sensitive, and there are ethical concerns over it. And there were different split learning configurations. So one is this, this vanilla configuration, which you see in the first figure. So here there is actually sharing of labels. Okay. So when I say labels, it is for example, you take a classification task. So you will see if this the classifying labels. So there is input data, and if the disease is present or not, that is the label, in a classification task. But in the vanilla configuration, okay, you actually share the labels with the server. Okay. But you also have the second configuration, that is the U-shaped configuration, in which even the labels does not leave the client. Okay, so it's very much secured. And then you also have this vertically partition data. So that is when you have multiple institutions. So, for example, you have the dermatology center that is in a hospital, and then you have a pathology center. Okay, so if all this, multiple centers, they want to train a model, but they don't want to share the data between them. Okay, so in this case, you use a split learning technique like that. Okay, and also the labels are, not here. The labels are shared to the server. Okay, but the raw data doesn't leave the client devices. So these are all privacy preserving learning techniques that are used in the healthcare hospital scenarios. And we proposed a scenario like this. Okay, so you have the patients here, and like I said in the beginning, we developed digital twins for each patient. So DT1 is for the patient one in the the first room. Okay, and DT12 is for the patient 2 in the first room. Okay, and you have a digital twin server for this this particular room with 3 patients, and then you have a digital twin server 2 for this 3 patients in room 2. Okay, and then you have an orchestrator. Okay, so this can do either federated learning or split learning depending on what you choose. Okay, so when it is federated learning, the models are trained on this digital twins, and you send the model parameters, and the aggregated model is the model parameters are aggregated, and you send the aggregated model back to the digital twins. Okay, whereas in split learning, the model parameters are not sent. You only send the activations, because a portion of the model will be in the orchestrated, and a portion of the model will be in the digital twin. Okay, like how we saw in split learning. So, yeah, so this is when you have the split learning, and here we actually had autoencoder. So like in the previous work, so we had the encoder and decoder. So the encoder was in the digital twins. So in the DT11 or DT12. So we have the encoder in the digital twins and the decoder in the orchestrator. Okay. So, only the activations are, sent forward. Okay. And, there is no raw data that is sent from the digital twin. So this was very much secure. Okay. And we also compared it with federated learning. So, like I said, the orchestrated will behave as an aggregator. So the model parameters are exchanged here. Okay, so this is not very much secure like the split learning, because I said there are possible GAN-based poisoning attacks that can happen here. But still, there is no exchange of raw data here. Okay. So we, compared 4 techniques. So we actually first developed, the 3D models, okay, for our metaverse scenario. So you have patient 1 with the heart and lungs organ, patient 2 with heart and lungs organ, and patient 3 and with heart and the lungs organ. Okay, and these organs animate based on the real data. So if the doctor, puts the oculus, he wants to monitor, he wants to analyze or diagnose something with patient 2. He moves, navigates, and he can rotate the heart organ, and he can see, analyze all those things. Okay. But at the back end, we also have the digital twin that is running the machine learning model. So we compared 4 cases. One is the standard split learning. Second is the standard federated learning. And next, we were comparing it with 2 other strategies. One is called selective federated learning. another one is called novelty-based federated learning. I'm going to just briefly, say what this selective FL and what is this novelty-based FL. Okay, and again we used a simple LSTM, autoencoder. So meaning that each patient is going to have a digital twin, and each digital twin is going to have a personalized LSTM autoencoder, which on in real time is receiving the the heart rate and lungs data. And this autoencoder, if it's detect any anomalies, that is if it detects any irregularities in the patterns, it is going to alert the doctor or the patient. Okay, so this is the reason for having an LSTM autoencoder in the digital twin of the patient. Okay, and we are using simple models, for example, in the size of 50 kb. So these are not like complex large scale models. So simple models that gets input as the the heart rate and lungs rate, and so for example it has just 13,000 parameters. And what is the selective federated learning that I'm comparing with, the standard federated learning? Meaning that, these hospital networks, they are resource constrained networks. And, when you actually, now I'm showing examples, with simple numerical data. So I am showing examples with heart rate data and lungs rate data. But what about the scenarios when you have, large image classification models with complicated convolutional neural networks? So in that case, you need to be sending a lot of model parameters between the edge nodes and the central service, or in this case, the orchestrator. So we were actually comparing with selective federated learning. So in selective federated learning, instead of all the digital twins that are sending the model parameters, only the digital twins, that have been performing well, that have been getting low training losses, participate in that particular federated learning communication round. So, this will actually result in lesser, consumption of communication resources. And another approach was we were comparing with the novelty-based federated learning. So this will actually, consider the novelty. So, we will calculate the difference between the global model and the local model. So global model is, the model that was updated and sent from the the aggregator in federated learning. And local model is something that you train the global model, and after training, what you have is the local model. Okay, so when you see the difference, it shows the novelty. Okay, so if the difference is higher, it means the model has been updated a lot, and it means the model is having a lot of novelty. And these models are important, but in some cases, the difference will be less, meaning that the model has not been updated so much, or has not been learning a lot, or there in that case there is no point in sending that model again. So in this approach, we actually send only the models that have been updated a lot. So in this way, we also reduce the the communication resources significantly. And in order to set a threshold for doing this, we actually set two thresholds. So one is the initial threshold we set at the initial communication round in federated learning. Another is a decay factor. So we, after some iterations, we reduce this factor. So we compared the standard split learning and the standard federated learning. And we saw that the standard federated learning was consuming less data transmissions, lesser data in the data transmissions than the standard split learning. So this is something very much important to see, because you in resource constrained hospital networks, you need techniques that is actually consuming less data, because bandwidth and constraints are there. And then we also, compared with the three federated learning variants. So in that, we found that the selective federated learning consumed even much more lesser data, because, only the digital twins that have models with, that have good performing models participate in the federated learning now. So this was consuming much more lesser data. And this is, when you, depending on the threshold, okay, you set the nodes participate in the federated learning round. Okay, so depend. So here alpha is the initial threshold, and tau is the decay you set. So depending on that, also the total data changes. So if you actually set a very low threshold, then means many more nodes will participate in the federated learning round. But if you set a very high threshold, then there is obviously less nodes will participate in that particular federated learning round. So, obviously the total data transmissions will be lesser. And this work was again, it was presented in the recent conference, IEEE conference on standards for communication networking that happened in Bologna in Italy. And finally, I'm going to talk about the resource allocation, in this metaverse scenarios, and I'm going to finish it, and I can get, questions from you. So, and one of the the research issue in when you're developing such metaverse applications is when you're feeding, you have to feed first of all real data from your sensors or the wearables that the patient is wearing. But there are bandwidth constraints, okay, in the hospital networks. So you need to prioritize the data that is being sent. Also here in when you deal with highly sensitive data, the second issue is the age of information. Okay, so the age of information of the sensor data, because if the doctor is actually visualizing the organs in his immersive virtual reality, okay, the doctor should not be seeing the animation of an organ that was supposed to be seen in the past 5 seconds, meaning that you should not be seeing that was happening in the in the past. The doctor should be seeing that is happening in real time, and so the sensor data has to be sent in real time. Okay, and especially critical data has to be sent in real time. For example, when you deal with heart data or breathing data, you need to be they are critical data and they have to be in real time. Otherwise, for example, like when you see sensor data like temperature, okay, it's not something critical. Okay, if the body temperature is not something critical, whereas the heart rate and the breathing rate is critical. And we are working on a resource allocation technique that allocates resource and prioritize the transmissions based on the age of information. Okay, so like I said, there is limited network bandwidth, okay, and age of information is something important when you're dealing with sensitive healthcare data. Okay, so we wanted to optimize the sensor transmissions, okay, and the bandwidth usage to minimize the age of information. Okay, so you cannot be sending a heart rate data that was collected or that was generated by the sensor 10 seconds back. Okay, it should be like instant transmissions. Okay, so we actually developed a reinforcement learning based approach. Okay, meaning that we actually considered three sets of data. So we again went for heart rate, breathing rate, and we also considered temperature. So in that case, the critical data is the heart rate and the breathing rate, whereas the non-critical data is the temperature here. Okay, so we wanted to allocate limited bandwidth, okay, in order to minimize the age of information. Okay, and also there is a single queue, meaning there is a single channel. Okay, so the agent, okay, the reinforcement learning agent has to prioritize the critical data, also has to use the bandwidth efficiently. Okay, and the reinforcement learning agent has to take action whether to send the heart rate data or whether to send the breathing rate data instantly in the channel. Okay, and we also we were considering a channel state model, so the well-known Gilbert Elliott Markov model, which has like good state and bad state. So we considered the bandwidth, we considered the age of information, we considered the channel model. So the agent will consider all this factor and has to take an action of sending whether the heart rate or the breathing rate or the temperature data. Okay, so we formulated this reinforcement learning problem. Okay, and the state vector is like this. So the age of information of the heart, the lungs, the temperature, and also the normalized Q value of the heart, lungs, and temperature. When I say the Q, this is the Q because there is one single channel, there is one single queue in which there is heart sensor data, lungs sensor data, and temperature sensor data. But there are like three virtual queues, okay? And so how many values of the heart rate data is waiting in the queue? So that is the, the queue length of the heart sensor data. And how many values of the lungs sensor data is waiting in the queue. Okay, so all we are also considering the queue length factors and also the available bandwidth and the channel state. So whether, at the moment if the channel is in the good state or the bad state, okay? Because, the Gilbert-Elliott model will give the transition probabilities from going from good state to bad state, okay? So, and based on that, we were, allocating the reward. So, if there is a high, age of information value, we give penalties. Okay, so negative values. And if there is, excessive bandwidth consumption, we give penalties. Okay. But we, if it is the other case, we give positive, reward values. Also, we are considering of, apart from all this age of information and bandwidth values, we are also we are also planning to consider the patterns. Okay, so meaning that sometimes, the heart pattern might be abnormal. Okay, in that case, the heart rate has to be given priority for, for the transmission from the edge node to the, the metaverse server, the server that is, hosting the digital twins. Okay, so, if it, the pattern is normal, okay, you don't need to send the data instantly. But if there is an abnormal pattern, okay, in the recent past, such data has to be sent, instantly. Okay, so we are also considering the patterns, okay, inside the state vector to, take an action. Okay, and these are, and these are, the results that we achieved. Okay, so the reward was actually increasing, meaning that the, the reinforcement learning model was learning well, okay, in taking the, the actions. Okay, and you can see in the right side graph that the average, the age of information value of the heart, lungs, and temperature was decreasing. This is good because, all the time in which, the sensor value is waiting in the queue has been reduced. So if this is decreasing, it means that, the data is sent instantly, okay, almost in real time. And it is not like sent after many seconds. Okay, so this is all about, the three directions in which we are working on. So one is the organ level digital twins, the patient level digital twins, and another is this resource allocation problem, which is very, very important when you have healthcare networks. So thank you very much. And now I'm open to questions if there are any questions.
Participants, you can post your questions in the chat box or you can unmute and ask him. Any questions, participants?
Yeah. I mean, you can focus on the technicalities. Like you can just focus on the machine learning criticalities, or the importance of the sensor data. But metaverse is something that is getting a lot of attention in the recent years, especially with the, healthcare, because of for the advantages that was I was discussing. So metaverse is also a very good, a research problem. Any resources for digital twin? I don't understand if you for learning. Okay. I mean, there are of course online resources that you can use if you want to, study about digital twins. I hope you mean, you are asking for that.
Sir, this is Shalini speaking.
Okay.
Let's say I'm trying to work on detection of depression. So
Sorry.
if I try to make use, let's say I'm trying to make use of this virtual reality in order to detect depression.
Okay.
So how can we try to make use of this metaverse and then try to detect whether that person is having depression or not?
You actually, I mean, don't need the metaverse framework for detecting that. You just need, machine learning algorithms probably. And but if you want to monitor or if you want to, analyze such people and like, you want to get alerts, then you can, use metaverse. But you can just take a model and you need a camera that monitors and gets such I mean it's going to be sensitive data, and then you can run a machine learning model that is going to detect any irregularities, and it can alert the person who wants to monitor, also the patient who is undergoing depression. So this can be also done in the same framework or the same pipeline that I was talking about.
Okay, so there is no scope of we have only scope of improving their mental status. We will not be able to detect or predict something like in using virtual reality. Is that so?
If you're able to monitor the patient and if you're able to get data and do that, you can actually detect. Again, like I said, you can run a simple model that is learning the patterns, and if the pattern of if the behavior is changing, you can detect it, and you can warn the patient. I mean, you can alert the patient that you're going from a normal state to a depression state, something like that.
Okay, thank you, sir.
Any more questions, participants?
Okay. For collecting data, I mean, it's not easy to collect healthcare data. I'm working on also other applications, for example, like vehicles. In that case, it's easy to collect data, but again, for healthcare, it's not easy. So if you're doing research and you want to develop models, you can use data sets. There are many publicly available data sets, or you can talk with universities and see if there are or hospitals and see if they are providing data, because sometimes we actually get some data from the public hospitals here. So in certain cases they do not provide data. Or you can also buy sensors, get sensors or wearables, and then collect data by yourself. Like smartwatches are limited to collecting only few data, but you also have sensors, you also have cameras to collect a lot of data.
I think the questions are over, sir.
Yeah, I think there are no more questions. Thank
There are
you.
no more questions. Thank you, sir. That was a very interesting session. Your expertise in digital twins and metaverse, along with your research perspectives, have truly enriched today's program. We deeply appreciate your time and contribution. Thank you so much, sir. Participants, the feedback link will be posted now in the chat box. Kindly fill the form before leaving. Let's meet again tomorrow at 2 p.m. Thank you all.